I just want to make an interesting comment from my field, which is psychiatry, about botulinum toxin, which has certainly gained in popularity for wrinkles and for headaches. But there's been studies that show that people that have had botulinum in the forehead, their depression is considerably reduced. Now, why is it an antidepressant? The current prevailing theory is that they're not frowning anymore, and that reflex, if you don't frown, you can't feel bad. If you don't look bad, that kind of biofeedback. Or because you're not frowning, people look at you because they don't think people avoid people who are frowning. So which way the biofeedback works, it is interesting that botulinum toxin is now a treatment for depression, off-label, of course, but interesting. Our next and last speaker this morning is Dr. Paul Vespa. He is a professor of neurosurgery and neurology and the director of Neurocritical care. Dr. Vespa's main areas of research is pathophysiology of acute brain injury and designing critical care treatments based on a brain-first approach. His expertise in critical care of the brain, neuromonitoring, and clinical neurochemistry are an asset to the Brain Research Center. Dr. Vespa holds, and these are acronyms for NIH grants, an RO1 award to examine metabolic functioning in the brain after severe head trauma using magnetic resonance spectroscopy. He also holds a KO8 award to study NMDA, which is used in psychiatry too, you'll hear more about that, and methyl D-aspartate, receptor dysfunction after traumatic brain injury. So I look forward to hearing that talk. Dr. Vespa?
Right behind you.
Oh, behind me, okay. My third eye wasn't working.
Very good. Thank you very much. Well, thank you, everyone, and I want to thank Dr. Varma and the selection committee for having me come out here. Can you guys hear okay? Hear well? Well, I PHI, I suffer from migraine headaches, and so, lack of sleep, a little stress, a little different diet, red wine. So if I start having a migraine right now, just give me a break. I'll go take an ibuprofen right away. But we're going to switch gears, and we're going to talk about stroke and varieties of acute care neurology, under the auspices of neurocritical care. And so it's a little bit different than the outpatient focus and the more day-to-day practice focus. So we're sort of switching gears and talking about, for more or less, more critical patients who may be hospitalized or in emergency rooms. What I'd like to try to do today is to talk about some common scenarios that you're probably going to be faced with, decisions that would have you weigh in on and try to help your patients make decisions on. The first two are going to be about acute ischemic stroke or ischemic stroke and stroke prevention. And the first one of those is going to be about carotid intervention, what to do with a patient who has carotid artery stenosis, either symptomatic or asymptomatic, and what to sort of recommend to those folks, and specifically drilling down on the controversies about carotid endarterectomy versus carotid angioplasty and stenting, CAS. And then we'll go on to talk about acute stroke therapy, specifically thrombectomy, currently, and where we stand with acute stroke intervention. Should we be doing thrombectomy, and if so, in what kind of settings? And then the third emergency kind of situation will be blood pressure control for the acute patient who has an intracerebral hemorrhage. There's been some very nice recent papers on this, and really what is the best number or what is the best guideline and approach to those kinds of patients. So really delving more into the more hospitalized acute patient. So carotid artery stenosis is really a common problem. It affects many patients, both in an asymptomatic way and a symptomatic fashion. Oftentimes, these are discovered after a patient's had a TIA event, and you put them through the standard battery for a stroke evaluation. Or perhaps they're more of a high-risk vascular patient who already has some degree of cardiovascular disease, and you're doing a primary survey just to try to evaluate whether or not they have a risk factor for stroke. Carotid artery stenosis, we basically talk about this as at the common carotid or internal carotid artery, and this is basically atherosclerosis, which is narrowing the caliber, narrowing the diameter of the vessel. And there's a couple of different ways of thinking about the degree of carotid artery stenosis. Carotid stenosis can be described as mild, moderate, or severe, or can be given a number or a percentage stenosis. And it can be defined in two different ways based on whether you follow the North American trial list called NACET or the European trial list called ESCT. But if you look at the screen here, you have basically, from the bottom, you have the internal carotid artery, internal carotid artery, common carotid artery, then the internal carotid artery, and then above the neck. And right at the bulb is where we sort of have this stenosis occurring. And no matter how you define the stenosis, the formula, this looks pretty bad, pretty severe. And NACET basically, which is the way in which it's described in North America, takes the internal carotid above this, minus the carotid right at the bulb, and then kind of divides it by the supra-bulb internal carotid artery. And that's the degree of stenosis. And you can see that there's just different ways in which things are estimated, but by and large, what we're going to be talking about is this formula. So when we say that it's 70% stenosis, that means that this segment is 70% of the internal carotid artery above. Now, there's different ways and different sensitivities of screening for carotid stenosis. Carotid ultrasound, CTA, angiography are really the three ones that are very prominent. There's a lot of debate as to which one is the most accurate and least accurate. I think that whatever you're using, have it be standardized. If you have a good standardized lab for carotid ultrasound and a good technician, that's very good and reasonable. It's still supported by guidelines. But nowadays, oftentimes we're doing other kinds of assessments, including CT angiography of the neck. And so hopefully they're using the same kinds of standards. Now, what are your options for treatment for this disease? Well, broadly speaking, there are two types of techniques: the carotid endarterectomy and the carotid angioplasty and stenting. So, carotid endarterectomy is this open surgical technique. It's classic. It's been around for at least 60 years, if not longer. It basically involves making it open. The yellow here is supposed to be the carotid plaque. Making it open of the vessel, really taking out the whole plaque, and this is kind of a cartoon appearance, which looks kind of nice and neat, but in point of fact, this is usually very irregular and unstable and has hemorrhage in it, and as well as just the yellow plaque. And then basically putting a graft over this, and so the whole vessel basically becomes open. The second technique is the carotid angioplasty and stenting, which is basically an endovascular problem, an endovascular technique in which a carotid vessel is canalized in angiography, and then a balloon is put in to basically blast open the plaque, and then a stent is left in place to keep the plaque from recollapsing in and for restenosis to occur. The plaque, if you will, is basically compressed and or dislodged. It's not really removed, so the plaque is still there. But the vessel is recanalized back to hopefully a pretty large diameter. The NACET study came out many years ago and really set the standard for what is considered to be the acceptable rates of stroke from medical therapy versus surgical therapy. And it was a very important study in its time, and really it established a couple of things. It established what the acute complication rates are for a surgical technique to open up the vessel, and it established sort of what the longitudinal risk, at least over 3 years, is of recurrent stroke. And at the time, it was really a definitive therapy that basically said it is much better than medical therapy. Medical therapy at the time being antiplatelet medications that were available at the time, mostly aspirin or dipyridamole, and lipid-lowering agents which were available at the time. Now, in some ways, this is sort of ancient history because we have much different medical treatments right now. However, it still is kind of considered the gold standard approach. And so, specifically, the risk of having, for symptomatic disease in patients who have had a carotid endarterectomy, the risk of stroke at 3 years for severe stenosis is about 8 or 9%, versus medical therapy, which is about almost 28% or a little bit higher. And so that's a really low risk rate overall. And it's, in the NACID study, it was significant. In the European study, it was also significant. And the number of strokes that you prevent are a large number, 200 strokes at 3 years. The number needed to treat is 5, which is an enormously low number. It means that really for every 5 that you treat, you're really going to you're going to help somebody prevent their stroke. And I think that's really significant. That's much better than many of the things that we do in medicine and in surgery. So this has become the gold standard. And that 9%, you'll see, has been codified in some of the guidelines. And we'll get to the guidelines in a little while. So what to do for patients based on these results, which is really the definitive study in carotid endarterectomy. And we break this down based on whether patients are symptomatic or not symptomatic. And the symptomatic means they've had a TIA or a small stroke or even a large stroke. Asymptomatic means they walk in the door and they haven't had any of those symptoms per se. Well, if you're asymptomatic, you really have to have a stenosis greater than 70% in order for you to benefit from doing surgery of some kind. And you can undergo carotid endarterectomy, but the complication rate by your surgeon has to be pretty low. It has to be about 3%. So when you're evaluating a patient who's asymptomatic, who has maybe, let's say they have an 85% stenosis, and you're considering referring them on to surgery, you want to know from the surgeon, really what is their complication rate, and that should be something that's known. So it should be, if you're going to consider sending them, especially if the patient really wants that carotid fixed, then you really have to send them to a highly qualified surgeon. In the NACID studies, and in some of the other studies that you'll see later on, the surgeons have to report this and have to have a high competency rate, low complication rate. If one is symptomatic, then in other words, TIAs or stroke, then carotid endarterectomy is indicated, and really they don't have a complication rate here outlined, but in point of fact, nowadays they want the complication rate to be pretty low, and in the guidelines they actually will talk about that. I'll show you that the complication rates are based on the NACID studies. And then the patients who are symptomatic but have kind of 50% or more, yes, they should have a carotid endarterectomy that's indicated, and the complication rate needs to be low, less than 6%. Less than 50% stenosis, really medical therapy is the recommendation, and the other surgical treatments, CAA and carotid stenting, are not really recommended per se. So it has to be pretty significant. You're either symptomatic and you have a fair amount of stenosis, or you have a high degree of stenosis if you're asymptomatic. Now, carotid angioplasty is the other major intervention now for carotid disease. Angioplasty basically is placing a balloon catheter, as we said, and angioplasting it open. Here's one example of this before and afterwards in which the angioplasty was done. Many of these devices now have balloons, but also have protecting devices. So this is a picture shown to the right here where you have, this is the proximal end, this is the balloon protection device. This is another type device where the proximal end is here. This is an umbrella that basically prevents the clot from getting, when you're angioplasting, the clot going north and going into the brain and actually causing a stroke. Because that's the major risk from either procedure, is that when you go to do the procedure, you're actually having a stroke, which is what we're trying to prevent, right? So we don't want that to happen. Well, there were a number of studies that came out then looking at carotid stenting versus carotid endarterectomy that have come out over the last 10 years or so. And this was the Sapphire study, which was which is now 10 years old, but one that really put carotid angioplasty on the map as an equivalent procedure with carotid endarterectomy, and has really influenced the last decade of care. And basically, these were patients who were brought in who basically were symptomatic and asymptomatic. So they could be high-grade stenosis without symptoms, or they could be relatively lower grade, 50% with stenosis. And that's actually one of the criticisms now of this study, is that they kind of have a wide range of disease for these patients. Patients who are considered high risk for surgery, in other words, they had cardiovascular disease, undergoing anesthesia was not going to be a good option for them. So they ethically could be randomized to what was considered to be an experimental procedure at the time, and studied against the standardized procedure, the accepted procedure. So 167 patients per group. They were given aspirin. They were given the particular stents. They don't really have a lot of details about the carotid endarterectomy. as opposed to the NACIT study. NACIT study was very rigorous. The surgeons had to meet extremely rigid guidelines beforehand. Not so in the Sapphire study. However, I've been told that the Sapphire surgeons were very good surgeons, and many of them were also NACIT surgeons. So there you go. The primary endpoint, which is shown on the bottom next to the star, indicates that there was a very similar rate of the primary endpoint, which is stroke, death, or myocardial infarction, in both the stenting and the carotid endarterectomy group. And in fact, the stenting group actually had lower rates of 12% versus 20% for the intention to treat, and it met statistical significance. And this was basically events within 1 year of the event. So this really suggested that for cumulative events, that carotid stenting was really very good. The critique of Sapphire, which followed, was, well, this is a combination of asymptomatic and symptomatic patients. This was kind of an outcome of all morbidity and mortality, both myocardial infarctions and stroke and death from any cause. And that's kind of very broad. It's not specifically just stroke or specifically something else. And no functional outcome. How did these patients actually do? Quality of life. And they were worried that the carotid endarterectomy arm was not very well controlled for. This therefore led to another study being constructed, which was called the CREST study. And the CREST study ensued thereafter to really try to compare carotid endarterectomy against carotid stenosis in hopefully a more robust way. This paper was published a few years ago. And again, basically, this was a very interesting study that looked at outcomes for these patients. And what it showed there was that if you looked at myocardial infarction, so again, these were high-risk patients that were going to, if they underwent carotid endarterectomy, were going to perhaps have strokes or heart attacks on the operating room table or perioperatively. What they found is that they, in fact, were high risk, and they had more myocardial infarction perioperatively if they had the carotid endarterectomy. It was about 2% versus 1%. However, strokes were more common in the angioplasty group. So they were not, as they were just breaking up this clot. Some of the clot was going north. They were causing strokes. And in fact, that's what they had. They had, even with protection device, and all of these were angioplasty devices with protection, they were having that happen to them. Periprocedural stroke and combination, again, and death was actually more common in the angioplasty group. However, at the time, so that's the real data, but the punchline from this study that came out at the time was that these were sort of equivalent. Again, that's not really necessarily true. What's interesting is if you look for age, and again, this is an older age population, that interestingly, it looked like the older patients actually did better if you had carotid endarterectomy versus the younger patients did better if you had carotid angioplasty. So perhaps there is an age effect based on comorbidities and other problems. Maybe the elderly really have a different sort of outcome, but the distribution was pretty similar. There have been a number of other studies now, and this is just a quick summary table of these, that have basically said the same kind of thing, that carotid endarterectomy is actually as good as or better than carotid angioplasty, and especially in the European study, carotid angioplasty patients did worse overall. They had a higher rate. This was this one here, the ICSS, which is a 2010 paper, which came out just after CREST. The carotid angioplasty patients had more complications, and carotid endarterectomy was better. So there have been some criticisms now. There have been some subsequent papers looking at a variety, the whole history of publications of carotid angioplasty and carotid endarterectomy. And this is a very nice review paper from a couple of years ago, which actually divides it up based on whether you're symptomatic, your carotid stenosis is symptomatic and you're having TIAs and strokes, or whether you're asymptomatic and how patients do. And what's shown here really is the rate of stroke and death. The rate of stroke and death in symptomatic patients with carotid angioplasty across time. And as the numbers are coming down, and really now, stroke and death, the incidence of that in carotid endarterectomy is 3%, and it's 6% in angioplasty. If you're asymptomatic, there aren't too many studies really to compare. There's just the CREST study, so we don't really know with carotid angioplasty. So looking at this, it seems as if even with symptomatic patients that carotid endarterectomy is still preferred in terms of the overall complication rate and long-term risk rates of revascularization. And this has now led to a number of these guideline-type articles coming out that basically saying that it's, these two techniques are really not equivalent and that carotid endarterectomy is actually superior. And so as you're thinking about referring your patients and thinking about the risks involved, I think looking at the complication rates are important, and keeping this position paper in mind is useful. These are the actual guidelines that have come out and were published in 2011. And it basically says patients should undergo carotid endarterectomy if you have symptomatic disease and you're more than 70%, and these are patients who have had TIAs or strokes, et cetera, in the last 6 months. And that's really the preferred method of intervention. They also then go on to say that carotid angioplasty is an alternative if the patient is really difficult, they can't have surgery, if there are some technical aspects of the clot, of the stenosis that you just can't get to by regular surgery. And probably the most important thing from these guidelines have been this new effort to try to do the revascularization early after a stroke, early after a TIA. And so now what they're saying is that really you should be evaluating the patient with ultrasound or CTA or some other imaging technique quickly during that acute TIA event and getting them to surgery within 2 weeks. And that is they don't talk about large strokes here, and there may be some trepidation of doing a patient who's had a large stroke early on, but really this is now the advice and counsel to try to get these patients into having surgery early. After carotid endarterectomy, there's the perioperative care is somewhat complex because you need to reduce their blood pressure in the perioperative period to actually lower blood pressures than they were prior to having surgery performed. After surgery, there's this feared complication called the cerebral hyperperfusion syndrome, or CHS, which basically represents an abnormality of cerebral pressure autoregulation after surgery. These are patients who have had a carotid stenosis, so they're not getting a whole lot of blood to their brain. So their brain is sitting there, and the little blood vessels inside of the brain are wide open, like a catcher's mitt, saying, "Send me all the blood you can." And now all of a sudden, what do? You open up the pipe, and so those blood vessels are wide open, and now they're seeing a torrent of blood flow going to them. And they don't have the ability to constrict anymore. It takes them time to relearn how to do that. Why that is, we're not really sure. But during that period of time, you could basically cause a brain hemorrhage because the blood vessels are wide open. So this is just an example of a preoperative blood flow study in the brain. Beforehand, this is the side of the carotid endarterectomy, and afterwards, the red says that there's high blood flow going on there. And that we don't really want that to happen. So what you really need to do is you really need to lower their blood pressure and keep it low for some period of time. We don't know how long necessarily. Some people have said many days. Clearly looking at symptoms. So how do you know that they've had a carotid endarterectomy and their blood pressure is a little bit high? How do you know, well, are they having this problem of cerebral hyperemia? Well, if you have to look for clinical symptomatology. If they're having headache, if they're having altered mental status, if they've had a seizure, then they're probably having this syndrome. You need to lower their blood pressure emergently. A CT scan may show cerebral edema, may actually show a hemorrhage, so getting a CT scan to look for a stroke, look for cerebral edema will be important. Lowering the blood pressure and keeping it down is the real treatment for this. Now I'm going to switch gears a little bit and now switch to more of acute stroke and acute stroke intervention. It's been a very exciting couple of years for acute stroke. We've had a dramatic increase in the utilization of TPA in emergency rooms. Some of that's been facilitated by telemedicine. Some of it's been facilitated by expansion of our time windows for the utilization of TPA. So for really up to the last 3 years, up to 3 years ago, TPA time window was really just 3 hours. Now it's really expanded out to 4.5 hours for most everyone except the elderly elderly who have diabetes, and people who are on any degree of anticoagulation, Coumadin, at all. So the 4.5-hour time window now has given us the ability to treat more and more patients. However, there are patients who come in who are outside of that 4.5-hour time window, or for some other reason can't get IV TPA because they have one of the contraindications, such as recent surgery, or they actually are on some type of anticoagulation. So what can one do beyond 4.5 hours for acute ischemic stroke? Well, there's really two types of treatments that are now being done. These are both interventional treatments for these patients. One is giving intraarterial TPA, which is given at smaller doses that are on the 5 to 10 to 15 milligram dose, directly injected into the blood clot. That's something has been done, although it's being done less and less these days. Or thrombectomy, which is basically putting in a device endovascularly into the vessel and pulling out the blood clot. Now, many of these techniques are being restricted to large centers or academic centers, but by just a show of hands, how many of you have been involved or seen thrombectomy in your practices or in your acute emergency patients? So not that many, but this is something that's developing and growing, and many medical centers that are moderate scale medical centers, not really small hospitals, but more moderate size hospitals, are actually hiring interventional radiologists, neuroradiologists to do these procedures. They're envisioning that this is going to be the cardiac catheterization lab of the future. And there's a buildup of this occurring. Now, that's good and bad. It's good because it offers us more hope for patients who present with acute ischemic stroke. It's bad because that development is occurring in the absence of well-defined literature. But that's actually occurring. Their devices are now been approved by the FDA to be used for thrombectomy, really without necessarily benefit, without data showing benefit, and numbers of centers are starting to do this more and more. And that's been developing for the past decade or so. And last year, about a year ago now, 3 trials were published in the New England Journal. They were presented at the stroke meeting, International Stroke Meeting, and then published the same day. And these are 3 relatively large-scale trials. We'll go through these. But unfortunately, all 3 studies showed that this concept of thrombectomy does not actually impart benefit to the patient. The patients don't do better than standard medical therapy alone. So we're going to go through these. And I was involved in a couple of these indirectly. But this is the first one, which was called Synthesis. This is an Italian study, which was a randomized controlled study. It involved about 360 patients. These were patients who came in and within the first 6 hours of acute ischemic stroke got this kind of device put up into their brain, this thrombectomy device put into the blood vessel and sucking out the blood vessel. The device was called the penumbra. There's different devices, but basically this is a reasonable device which was used. And they got to the patients pretty early on after the event, and they got them evaluated. And this was the actual time to onset the treatment was 3.5, almost 3.45 hours. This is about the other group, which was a little bit less. And they looked at the outcome scores at 90 days. And the modified Rankin outcome scores are just how good you're doing. And basically, this is like a golf score, so you want the score to be low. 0s are perfect, totally normal, you're back to work as a physician. 1 is, you're doing pretty well. 4 is you can't walk. 6 is you're dead. And so this was the group analysis, and what you see is here, you don't see a whole lot of difference between the arms. And in fact, the overall statistical significance was very low, and there was a trend towards people doing a little bit better, but not really doing better than just IV TPA alone. So this was a negative study. This says this technique didn't work. The next study that came out was a large NIH-sponsored study called the IMS study, which used both IV TPA and intra-arterial TPA together. So everybody who had a stroke came in who could get TPA within the 3-hour time window, got 2/3 of the dose, and then went immediately to angiography. They didn't wait around, they didn't waste time, they went immediately to angiography, put the catheter into the blood vessel, and squirted, if they found a clot, squirted some more TPA in there. Again, the doses were 5, 10 milligram type doses, very small doses. So the cumulative dose was about the same as you would get with IV TPA. And this was also called IVIA type treatment. And they, again, looked at the modified Rankin scores at 90 days, and they looked at overall outcome. And again, what they found was that overall, they really did not have a significant benefit for outcome overall. And that patients, the overall percentage of patients who had good outcomes, 0, 1, 2, so pretty much normal walking or even mild deficit, was the same, as about 40% in either group. And so they couldn't prove that it worked better than just IV TPA alone. Again, kind of a negative study. The third study was called MR Rescue, and this was a study which got a little fancier. And what it did was patients who came in with acute stroke had an early MRI scan, and they looked at the differences in terms of the stroke size that was there initially and the potential to have a worsened stroke. So they actually looked at the diffusion abnormality, which was the structural damage, and they looked at the perfusion in the brain, which is the state of blood flowing to the brain. So if you have a pattern where a patient has a small, this is the diffusion image, a small stroke, but then they have a very large area of low blood flow, this says that the patient is at risk for having a much larger stroke. So this was what they were called the favorable pattern, in which they wanted to see if a patient had this kind of diffusion to perfusion mismatch, and they got therapy, were they going to have a small stroke or no stroke later on. And previously, this group, this was started at UCLA, Dr. Kidwell started this at UCLA, she had shown that if you have this kind of abnormality and you got reperfused, you're going to do really much better. And in fact, there's a study called the Diffuse 1 and Diffuse 2 studies, which actually showed just that. If you have this pattern, you're going to do better. So this might be the pattern to treat to make patients better with this intraarterial therapy. And so what they did was they said, okay, we're going to only treat the people that have this pattern on their MRI scan. Everybody comes in, they get IV TPA, they go and get an MRI scan. If they have this complicated pattern, we're going to randomize them to either get the intraarterial therapy or not, right? So good study. It took a very long time to get patients into this study, in part because, and most patients who were screened never got into the study. Most patients who came in who got screened went directly for the IA therapy. They got IV TPA and they were not randomized. They just went and got the angio. Why? Well, at the time, the belief was angio really works. Angio is much better than IV TPA. We are obligated to do this. They're going to have a big stroke. It's not ethical for us to withhold the therapy. And so very few patients actually got into this study compared to the screened population. I think that's important because this is a negative study also. When we go to this also did not show any benefit in terms of outcomes, no matter how you looked at it. When you look at the final total, there was no difference in terms of outcomes for the patients who got the IA therapy and those that did not. So this is another study that failed specifically to show that the IA therapy benefited this penumbral kind of pattern. I think that's important to note that many patients didn't go into it, they got the therapy outside of the trial. And this is a problem that we have in medicine. We have a lot of things that are being done outside of trials and not within trials, and so we don't know if something is going to work or not. I think, though, what's happened is these three failed studies have really markedly reduced the enthusiasm for IA therapy, and now what's happening is that people are being more careful, and centers are not just ramping up their capacities, but they're getting engaged in therapies and clinical trials. And what's developed then is a next generation of intraarterial devices. So, and let me back up for a moment, and I'll just focus on, I don't know if everybody can see this little guy here he's MR Rescue Man. And what he's doing is he's holding this catheter, and the end of the catheter sort of looks like a corkscrew. Okay? And in fact, it's called the Mercy catheter, and it is a corkscrew. It goes into the patient as a catheter, a very thin line of wire. But when you pull on it, it has a conformational change, and it creates this corkscrew. the corkscrew actually grabs onto the clot and pulls the clot out of the vessel, kind of like you're pulling the cork out of a wine bottle. And can't drink red wine because it causes migraines. But I mean, this is the idea of pulling the cork out of it. Well, this thing, having lived this for many years during its development, and they went through many generations. They started with the X1 and went all the way up to the X7s, kind of like airplanes. These catheters actually would break. They would conformationally change. They wouldn't really pull out the clot. So the rate of clot removal was minimal. This adds to the controversy, right? So if you're saying, well, is one car better than the other, but the one car is a lemon to begin with, how do you really know it doesn't work? How do you really know whether one car is better than the other, getting you from here to Salt Lake City, for example? So they've developed a new catheter, and this new catheter is called the Solitaire catheter, and basically is a combination. I don't know if I have a better picture of it, but it's basically a combination. It's a catheter that goes into the brain like this, and it comes out, and it kind of looks like a stent, and it kind of looks like a clot retriever, and it stents open the vessel, and it grabs onto the blood clot, and then you pull the whole thing out. So it actually has a much better rate of pulling blood clots out, and I'll show you that data in a minute. And so Jeff Saver from UCLA and colleagues published this paper a year ago, which was called the SWIFT trial, which basically compares this new catheter with the old Merci catheter. So the Merci catheter is the corkscrew. The Solitaire is the new one, which is called the stent retriever. And what's shown here is the degree of good neurological outcome. They actually had much better rate of clot removal. They had about 80% clot removal here versus about only, and I know the numbers don't add up, but clot retrieval was much better with the Solitaire device. The Merci device was much weaker. It was only about 30%. By comparison, when a cardiologist puts a catheter in to remove a clot, does an angioplasty and revascularization, stenting of a coronary vessel, that's about 70% to 80% successful, right? So now we have a device, the newest device, this Solitaire, is similar to the cardiac devices. And so that's now the controversy. Well, the trials don't count, even though they're New England Journal articles, because we didn't have the proper technology. So you can buy that or you cannot. It's belief at this point. But in this first trial, which is not randomized, but it's basically just a comparison trial, patients do better in the Solitaire arm. Their mortality is lower. This is the actual mortality curve, which is lower in the Solitaire arm. So this is the first indication that perhaps these patients will do better with the Solitaire. And now what's happening is there are about 10 trials out there, multi-center studies, which have very cool names. SWIFT-2 is one of them, or SWIFT Prime is one of them, and there's all kinds of cool names. 10 trials out there where they're actually doing randomized studies, medical IV therapy versus these new clot retrievers. And so we'll see. Probably in the next couple of years, we're going to see whether or not this concept actually has proof in the literature. So stay tuned. So right now, what people have said is that clot retrieval is an option, but probably should be an option in a randomized study so that all the patients go in so we can really evaluate whether or not this technique is going to work or not. I'm going to switch gears here. The last sort of segment is to talk about blood pressure control with intracerebral hemorrhage. So intracerebral hemorrhage is another one of these life-threatening stroke syndromes that occur, that present to emergency rooms, and has been a point of controversy. There are guidelines for therapy. The guidelines are being updated. But one of the controversial items is where to keep blood pressure for patients who have an intracerebral hemorrhage. So when a patient presents with ICH, they often have very high blood pressure, systolic blood pressures of 200. And usually what plays out is something like this, where the patient comes in, they have a hemorrhage. It's relatively small initially. They might be leaking. There's something called a spot sign, which actually can show that there's more hemorrhaging going on, and their blood pressure is high, and you want to reduce it. So what happens is that they get a dose of medication, and the red arrow shows that the blood pressure is 200. They get a dose of, let's say, labetalol, and the blood pressure comes down to like 160. That's fine. But then an hour later, the blood pressure goes back up again with the red arrow there, and now you're in crisis again. You get another dose of medication. The blood pressure comes down. That's good. But an hour goes by, and the blood pressure goes up again. It keeps going on and on. If you put that patient on a continuous infusion of a medication, such as nicardipine or clofidipine or some other drug, even labetalol, the blood pressure comes down and stays down into a nice normal range. And there have been controversy as to where to keep the blood pressure. And 4 years ago, when we wrote the guidelines, we kind of just put our heads together and said, well, the blood pressure should sort of be less than 180. We're not really sure how much lower it should be. And we really didn't have data or evidence. Now we have 2 large randomized controlled studies which suggest that the blood pressure can be reduced safely, at least, and that patients may be doing better if their blood pressure is lower. The first one, and they're both by the same group, and they're called the INTERACT group, and I'm going to take you through both studies. This is Craig Anderson led this group. This is a large study which was done in China and Australia. And what they did was they reduced blood pressure to less, they really tried to reduce blood pressure less than 160 versus less than 180. And they tried to get the blood pressure down very quickly. So one key parameter here is with the intracerebral hemorrhage patients, these patients are at risk for having hemorrhagic expansion early. You need to get their blood pressure down. You need to get it down urgently. So it's truly an emergency. And the blood pressure is a key parameter to treat in these patients who come in and present. So if a patient has high blood pressure and they're sitting, let's say they come to the office and it's hypertensive crisis and maybe they have stroke symptoms, get them to the emergency room, get a scan, and get their blood pressure reduced very quickly, because it's that first 3 or 4 hours which they can go from a small hemorrhage to a massive hemorrhage, a small hemorrhage that they can recover from. Many of these patients will recover to a massive hemorrhage, which is beyond hope. So it's really crucial and critical. And these are just the comparisons arm. They got the blood pressure lower. And what they found was that overall, that they had less hemorrhagic expansion in the group where things were invasively covered, invasively treated. And the hemorrhages did not grow as much. And in general, the patients tended to do better. Although their overall mortality rate was not any different in this first study, they proved that they could do this safely, and they proved that hemorrhage expansion could be reduced a little bit. So they went on and they did the second study, and this is INTERACT 2. And this was recently published about 9 months ago. And what they showed in this study is that they reduced the blood pressure very early on to less than, they tried to get it less than 140, which was really pretty low, really normal, versus less than 180. And they really powered it sufficiently to try to reduce the bad outcomes. Mostly these were small hemorrhages, and a hemorrhage of about 10 to 15 cc's is relatively small. It's considered a small hemorrhage. And they were very evenly matched. And they did a pretty good job. They got the blood pressure right around 140 to 145 range. Now, technically speaking, a lot of their patients didn't actually stay under 140. And technically speaking, there's only about a 10 to 15, they say it's about a 14-point difference in blood pressure between these two groups. So both groups were actually reduced in terms of their blood pressure. And that's important when we get to the outcomes. So both of the groups were really pretty evenly matched, and in some cases, the blood pressure really wasn't down here in the 140. So you could be a critic of this study and say they actually didn't meet their outcome parameters. They didn't really get them to where they wanted the blood pressure to be. But they found out it was harder to get the blood pressure less than 140 than they thought it would be. What they found was that there was a trend towards benefit in those patients who were intensively studied. That the patients who were intensively studied, fewer had major disabilities. But the p-value was at 0.06. It wasn't really less than the 0.05 that we normally consider, and the odds, the confidence interval really crosses 1. So statistically, this was a negative study. Although they have not presented it that way, they've actually presented it as a positive study. And the reason why is that when they looked at the modified outcome, the modified Rankin scores, again, 0-1 is good outcomes, and 5-6 are bad outcomes and death. What they found was if you were intensively treated with blood pressure, less than 140, you had better outcomes on this modified Rankin outcome score, and that did meet statistical significance. So most people now are suggesting that we should really try to keep the blood pressure probably close to 140 to 150 range. And we don't really know what the right number is because they actually didn't get it less than 140. So we have a little bit of a problem, but most people are saying we should lower the blood pressure more aggressively. The newest paper, which just came out a couple months ago now, suggests that if you get patients and you lower their blood pressure and you put them on a drip, and you keep their blood pressure really low, and you keep their blood pressure from having too much variability up and down, they actually do better than if the blood pressure is bouncing up and down. And this is a chart which is kind of hard to interpret, but basically this is a measure of blood pressure variability. The more variable the blood pressure is, the worse their outcomes are overall. So you want to be back here. You want to have the blood pressure be not variable and have it be very tightly controlled with an IV drip. So the kind of the interpretation of these data are get the blood pressure down pretty low. Now, what the right number should be, we're not sure. 140 to 145 is really where they kept it, so that's the best that we know. You want to have good consistency of the blood pressure. You want to avoid that variability of blood pressure control. So you want to have it come down and have it be very stable. So I'm going to end here to give time for some questions that you may have. I just want to have 3 take-home messages. The first is for carotid stenosis disease. Carotid endarterectomy is really the best choice for carotid stenosis patients. It has the greatest likelihood of long-term prevention for the patient in the patient who has a good surgical risk. If they're not a good surgical risk, then carotid angioplasty stenting may be reasonable, but think carefully and really examine who's doing the procedures because the complication rates matter. Thrombectomy for acute stroke is unproven, and we're awaiting that. So still, IV TPA within the 4.5-hour time window is still the therapy of choice. Blood pressure control should be done for ICH. 100 to 150 range seems reasonable based on the data. We don't really know exactly yet. More data will be coming. And pay special attention to avoid these blood pressure fluctuations. And with that, I'll end up, and I'm happy to take any questions that you have.
Where should blood pressure be in ischemic strokes? You were talking hemorrhagic.
So blood pressure in acute ischemic stroke. So it sort of depends on what kind of stroke it is and what territory of vessel is involved. So generally speaking, if you're considering giving TPA or you've already given TPA, then you should keep the blood pressure systolic less than 180. If it's a patient who has, you're not giving TPA and they have some kind of stenosis, a carotid stenosis, for example, then you want to let the blood pressure be as high as, systolic be as high as 220. If you have a patient that is fluctuating, you notice that when the blood pressure is lower, their stroke symptoms are worse, and when the blood pressure is higher, they get better, then you want to keep them a little bit higher. In some patients, we actually induce hypertension. For example, they come in and they've clotted off one carotid artery, and they're perfusing from collaterals, and we don't want their blood pressure to lower. We actually will raise their blood pressure to keep it up.
I'm sorry, on your last slide, it said blood pressure goal of 100 to 150. That's not a typo. It wasn't meant to be 140 to 150 as that study had.
Right. So we don't know what the yeah, it should be one. Actually, you're right. That's a typo. It should be more 140 to 150. You keep it in that ballpark range, probably better than keeping it less than 180. Yeah. But the other thing is, if they're normal, you don't want to really push their blood pressure up either. So if they're 120 and they have a hemorrhage, you don't want to really push them up. So.
I understand there are some new catheters, especially for carotid disease, that are flow reversal and clot restricting. Are the recommendations that endarterectomy is better because of long-term positive effects in preventing stroke? And would those new catheters have any impact on that decision?
Well, it could, but the device companies are getting out ahead of us. They're trying to have new devices that do a better job, that have less restenosis rates, that have better stents, and so forth. But the literature is based on sort of long-term efficacy. Carotid endarterectomy is better long-term. Question? So the question is that the elderly population may need a higher blood pressure than people who are in their 60s. Right. Yeah. Yeah, I think the general issue is that those blood pressures apply to everybody. How about if you have chronic hypertension? How about if you're elderly? Should the blood pressures be higher? Generally speaking, yes, that's what we've always been taught. You know, if somebody's normally very high, you don't want to lower them by more or really lower them low. However, the issue is that many of these patients who came in with this study that's had small hemorrhages, they're in their 60s, and they've had pre-existing hypertension, and they tolerated the lowering quite well. So I think it's open. We don't really know. You know, we don't really know if it's unsafe to lower the blood pressure. What these data are showing us now is it's probably safe and may be beneficial. Okay, that's it. Thanks very much.